I'd like to thank the committee for having me come here. I'm going to talk today about pharmacoinvasive strategy for PCI. This is my 6th visit to Dubai since 2011 when I first worked with Dr. Wael in Sharjah. For those of you unfamiliar, I finished my fellowship in 1982, so I have a lot behind my belt. A third of my practice is TAVR, a third is peripheral endovascular, and 1/3 coronary. So the definition for pharmacoinvasive strategy is stemming reperfusion at the acute phase using fibrinolytic agents and PCI in a complementary fashion. Now the outcome for this is been variable, but it is certainly useful in places that don't have PCI cath. Some of the definitions, we're all familiar with the literature by looking at the class of evidence being 1, 2, and 3, 1 being recommended, 2 may be recommended, and 3 not recommended. Similar to level of evidence, A being multiple randomized studies, B, a single randomized or not large randomized, and C, retrospective or registry. The agents available for pharmacoinvasive here in the Middle East is using tenecteplase. In the U.S. is TPA or alteplase in various doses. Streptokinase was the first one, but because of the development of antibodies, this is no longer in use. Let's look at a few. There are multiple trials, but I just picked out a few that I thought might be interesting to look at. So here's the STEMI pathway that we use. If you present to a non-PCI hospital, you get a fibrinolytic agent, aspirin, an antithrombin agent, and antiplatelet agents. You can receive then either standard medical therapy, which may be successful, and then you can have an elective coronary angiogram. But if you receive standard therapy and you fail for reperfusion, then you have to be transferred for rescue PCI to a PCI hospital. On the other arm, you can go directly to a pharmacoinvasive therapy, give half dose thrombolytic, and then be transferred directly to a local PCI hospital. So a couple of facts, primary PCI is still the best. If you can send your patient to get a PCI within the 90-minute limit, that is the best. But even in the U.S., only 25% of hospitals are equipped for primary PCI. And the door to balloon time is always greater than 120 minutes when you get transferred from the outlying area. So this still remains a problem even in the U.S. I found the registry from UAE from 2003 to 2006, identifying the characteristics of patients here in your country. You get free emergency service through the government hospitals. Low molecular heparin was the drug of choice, again, tenecteplase. And interestingly, the door to balloon time was 29 minutes average. I also found interesting that most of the patients were either dropped off in a taxi cab or they were let off by their family members, which of course to me is pretty incredible. There's 2 studies to look at. Gracia basically used 2B3A and tenecteplase, comparing this with just tenecteplase alone, and it found that if you add the 2B3A agent, there really is an increase of cerebral hemorrhage, and thus this has been abandoned. In Clarity, that's where one found that the fibrinolytic agents tend to increase thrombi and platelet aggregation, and thus antiplatelet agents should be given up front at the time of the non-STEMI or STEMI diagnosis. How about time to thrombolysis, 35-day mortality? It's greatest when you can give the thrombolytic therapy within 2 hours of the onset of symptoms. So this is the goal. The patient presents to the ER, and those patients should be given the fibrinolytic at that time. We just mentioned before about TIMI-3 flow, and in Gusto, of course, we know that 90 minutes has been the major goal for achieving TIMI-3 throw. But if you look at other studies, it's really all over the board. Some had door to balloon of 34 minutes, and some had a few hours. So it is not easy to have a door to balloon time of 90 to 120 minutes. If you look at the Transfer MI, which was a Canadian study, they found that even if you got to them within 6 hours, those patients did better, and pharmacologic therapy therefore could be afforded to those individuals. If you look at Horizons MI, This showed that bivalirudin could be given instead of heparin. The problem with bivalirudin, especially in this country, is it's very expensive, and most patients still receive heparin or low molecular heparin. How about using drug-eluting stents in acute MI? I remember when drug-eluting stents first came out in '94, and then we were not allowed to use DEFs at that time because people thought that the drug would interfere with the clot. But it is now the standard of care to use DEFs. But the patients that we're talking about here today are the ones who have failed reperfusion. Here in the Merlin study for failed thrombolysis, they found that you could still achieve a good endpoint if you were able to rescue these patients. Heart failure was less common if they got rescued, and strokes and transfusion were more common, again, secondary to the fibrinolytic therapy. Door to balloon time, mentioned before, it's very hard to achieve. Depends on the setup in your area, but if you take anything from this, 90 minutes is the standard goal. What about the culprit lesion or multi-vessel PCI? The patients in the primary study were eligible for multi-vessel PCI as long as they were able to achieve a good result with the main vessel and the secondary vessels had to have greater than 50% stenosis. And if you do multi-vessel PCI, the cardiac death, non-fatal MI, and refractory angina all were left in this subgroup. But if you looked at the culprit shock, it was the exact opposite. If they wasted time doing other vessels, these patients at 30 days had a much higher morbidity and mortality. But if you took it out to 1 year, all the results were pretty much the same. Repeat revascularization, of course, is higher if you only did single vessel because those patients are scheduled to come back for secondary intervention at some other time. So where are the guidelines today? Because they have undergone some change. We certainly know that if you can transfer the patients, those patients who even get fibrinolytics at another place will do better, even with transfer within the 3-hour zone. Transfer is important as soon as possible, but is not always available, especially in large rural areas. Here was the main change from 2012 to 2017. Now we're using radial access. We're now using DES over bare metal stent. Sometimes we're doing complete revascularization. Thrombus aspiration has gone away, as I've shown before. It tends to give you distal emboli. Some centers are using bivalirudin, except for its course, and enoxaparin is easy to use over heparin, and these patients get early discharge. So these are some of the changes that have come about through that time. Use of parenteral anticoagulants, again, your choice, heparin or bivalirudin. 2B3A agents, they're probably gone out of favor. We have abciximab in the U.S., but again, it's very expensive, and we have really not been using this in combination with thrombolytics. Everybody should be preloaded with either prasugrel or clopidogrel. It is your choice, depending on economics as well. So, from this, I can give you a few conclusions. This is the roadmap to the patients that present. Those who come to the first medical contact, that's seen up on top, if they can get to the primary PCI hospital within 90 to 120 minutes, that still is the goal. But if you're in the outlying area, then it is okay to give half dose fibrinolytic and transfer the patient. But if you know the patient is not going to be transferred, then you should give full dose fibrinolytic therapy. These are your choices: full dose fibrinolytic therapy and transfer them with an ischemia-guided plan. Do a primary PCI no matter how long it takes to get to it, or you can give reduced fibrinolytic and transfer them within the time frame noted. Take home these messages from this. The main limitation with primary PCI as perfusion strategy is it has a limited availability outside the primary medical centers, especially if not associated with medical school. Primary PCI is the reperfusion therapy of choice compared to fibrinolysis because it achieves a much higher rate of TIMI3 flow without the risks of intracranial hemorrhage and has improved outcomes. Currently, the guidelines recommend 90 minutes, but that's probably unrealistic in most places. If you can get to 120 minutes, I think you're still in good shape. And patients who are transferred to a PCI center have much better outcomes. than those who are treated with primary fibrolytics. Take-home message number 2. The optimal timing for routine angiography and PCI for pharmacoinvasive strategy hasn't been determined because there are some cases that are done even a day later with adequate long-term results. It's a safe and effective measure, especially in low-lying areas, to give pharmacoinvasive therapy, and this should not be withheld from any patients, especially if primary PCI is not available. And for those who fail fibrolytic therapy, those are emergency transfers to the primary PCI center, whether they're on mechanical support or not. Aspiration thrombectomy is out. Non-culprit PCI is sort of plus minus. It can be done as long as you don't spend useful time trying to open up an artery that probably is not as important as needed for that time. Once again, thank you for having me here. I'm taking